what happens in COVID-19 pneumonia? There are different respiratory treatment for different phenotypes because one size cannot fit all. So there are two distinct phenotypes in the. Remember, I am talking about the phenotypes, respiratory phenotypes, not the genotypes or variation of the virus. So I'm not talking about the variation in the COVID virus or mutation of the COVID virus. I'm talking about the respiratory presentation of the ARDS. There are two phenotypes, two possibilities can happen, where the PaO2 FiO2 ratio is around 95 or more, where the PaO2 FiO2 ratio is 84 or the less. So there are different management for these different conditions. So if we talk about the L type, there are two types, H type and L type. So first one, where the PF ratio is more than 95 is L type, and where the PF ratio is less than 85 is H type. What happens in L type of the pneumonia? There is a low elastance. Try to understand what does elastance means. If you are stretching a rubber, if it is a easily stretchable, it is called a low elastance. If it is a difficulty in this thing to stretch it, then it becomes a high elastance. So low elastance means easily stretchable, and easily imagine the easily stretchable thing is having a good compliance. A lung which can be stretched or which can be distended with a small volume has got a good compliance. So here this is a small misnomer. L type means low elastance. Side by side, it means that those patients who are having high compliance or good compliance, where we have to look for low ventilation perfusion ratio. Their lung weight is low. Why it is low? Because it is not consolidated lung, it is a clean lung. And there is a low lung recruitability because these are not a consolidated lung. So if we try to recruit them, they tend to over distend, and possibility of barotrauma can happen. Then comes the, what is the pathophysiology of this type of problem or this type of pneumonia? It could be a mainly a vascular problem. So what is happening when the infection happens with the SARS-CoV-2? It acts on the angiotensin receptors. So ACE receptors, it is acting on the angiotensin 1 and angiotensin 2 by using the angiotensin convertase enzyme 1. And what happens at the angiotensin convertase enzyme 2 level? This is activating there, and this activation causes a dysregulated inflammation, because the moment angiotensin 2 and ACE1 shedding happens, this causes a shredding of these receptors. The moment the shredding happens, they release the inflammatory cytokines, and there are the damage associated molecular pattern as well. These cytokines and DAMPs, they cause a widespread inflammation. And then in a subsequent stage, there is a hypoinflammatory endothelial dysfunction. Gradually, the angiotensin 2 and these receptors are totally shed, and at that time, there is a microvascular dysfunction, increased ACE2 expression because ACE1 is already shredded, and if severe, then it can cause a vasodilatory type of shock. So this is the vascular problem. You can see in the dual energy CT scan. Incidentally, this dual energy CT scan is not widely available with us, but expert has done this study where they have seen, if you can see here the arrows and you can correlate with the colored photograph, the preferentially increased perfusion of the lungs is happening proximal to area of the lung opacity. So those area where the lung opacity is there, proximal to that, there is a preferentially increased perfusion is happening. There is a decreased area of peripheral perfusion corresponding to the peripheral lung opacities, and there is a halo of increased perfusion surrounding the peripheral areas of the consolidation. So as you can see here, this is all causing the VQ mismatch. So what is happening in a viral infection? There is a subpleural intestinal edema or ground glassing of lungs takes place. This causes the vascular inflammation and vasoplegia. This leads into the hypoxemia. Another, if you see, there is one term called a P-SILI. P-SILI is patient self-inflicted lung injury. What is happening when patient is a hypoxic? Is he having a deep breath and rapid breathing? When the minute ventilation goes very high, more than 12 liter or 14 liter or 18 liter per minute, then this type of injury can happen. And then there is a negative intrathoracic swings that causes the increased respiratory drive, and that causes the increased in minute ventilation, and all this further, it's a cascade. Hypoxia will cause this, and this will cause self-inflicted lung injury, and again the lung injury will cause further hypoxemia. So this cycle will go on.